Hello, and thank you for joining this video presentation on HIV in adult primary care for 2016. I am John Cohn. I am an infectious disease internist and professor of medicine at Wayne State University. Today, I'll be providing concrete ways that primary care providers can participate here in Michigan in achieving the national HIV/AIDS strategy goals and contribute to the end of the HIV epidemic in our state. Here I show you the national HIV/AIDS strategy targets for the year 2020. On the right-sided panel, you'll see three bars on the plot. The first bar represents the goal that 90% of people with HIV in the United States will know that they have infection by the year 2020. The second bar represents that 90% of people who have been diagnosed with HIV will be engaged in care for their HIV infection. And the third bar, the lighter blue line, shows the percentage of people who should have a controlled virus by the year 2020. So this is really 80% of the number of people who know their status, or as you see in the upper right corner of the box, 72% of all people with HIV in the United States should have a viral load under 200 by the year 2020 by having been diagnosed, by getting engaged in care, and by having effective antiretroviral therapy. In this slide, CDC estimates the effect of antiretroviral therapy on the future of the epidemic across the United States. That first blue column illustrates 260,000 new infections that CDC estimates would occur in the U.S. between 2015 and 2020 if we continue treatment and prevention at the same levels that are currently implemented. The column on the far right shows a drastic reduction in new infections, down to about 80,000 by 2020, instead of 260,000. This reduction is accomplished by antiretroviral therapy, which reduces the infectiousness of patients, and that reduces about 160,000 infections. And then the provision of PrEP, pre-exposure prophylaxis, the high-risk persons, reduces infections another notch. So between these two interventions of antiretroviral therapy, there can be a drastic reduction in HIV prevalence and HIV incidence in the United States, and we expect similar results in Michigan if we expand treatment and prevention. How are we doing in Michigan? These are data from the Michigan Department of Health and Human Services. These treatment cascades lag a little bit because they have to collect data across the state, and they want full year data by the end of the year to show this. So this represents events through 2015. So in 2015, MDHHS estimated that there were 16,000 people living in our state that had HIV infection. 86% of them knew their status. A proportion of them were in care. And by checking the lab results across the state, MDHHS knew that 8,000 people had viral loads under 200. Were virally suppressed. So through 2014, 50% of people living with HIV in Michigan were virally suppressed. To achieve the NHAS standards goals by 2020, we want to get to 72% virally suppressed. And we need the participation of every healthcare provider in the state to achieve that. So here are some ways primary care providers can participate in HIV care and prevention in order to achieve that NHAS goal of 72% having undetectable viral loads, a controlled virus. HIV testing and referral, really everyone seeing patients can participate in this. Pre-exposure prophylaxis is something one can do with a high-risk patient that tests negative. That's in your practice. Co-management of HIV-infected patients would be doing the primary care of someone with HIV who's getting antiretroviral treatment from a consultant. Or you could choose to learn to do antiretroviral therapy for your own patients, which would expand access to antiretroviral therapy across the state, a critically important component of reaching the NHAS goals. In this presentation, we will talk about the first three components: HIV testing, pre-exposure prophylaxis, and co-management. And in the companion presentation on this website, we discuss antiretroviral therapy. So here we will start with HIV testing and counseling. In the last few years, the technology for HIV testing has changed substantially, so I want to bring you up to date on that, so you can be ordering the tests that are currently recommended and be familiar with interpreting them. This graph shows the first 100 days of infection in a theoretical patient. Time zero is the moment of HIV infection, so the sex act during which HIV is acquired. About 10 or 11 days later, HIV RNA, representing HIV virus, becomes detectable in the bloodstream. So between time zero and day 11, there's no way to know the person has acquired HIV. The virus is just in regional lymph nodes. There's no measurement we can make, and that's now called the eclipse period. Starting on day 10 or 11, when there's HIV RNA in the plasma, many HIV tests, including an RNA test or a viral load test, would be positive. Within a week of the virus appearing in the bloodstream, the HIV P24 antigen, a structural protein of HIV, becomes detectable in the bloodstream. And that's when our newest tests first turn positive, our newest diagnostic tests. A few days later, IgM antibodies against HIV become detectable, and the third-generation antibody tests would become positive. Some time after that, IgG antibody is positive, and the older second-generation tests would become positive. Over the next couple of months, both the P24 antigen and the IgM antibody disappear from the blood. So after that time point, we would diagnose HIV with the standard IgG antibody test, and we would confirm it, finding HIV in the bloodstream of someone who's not already on medication. So this shows the generation of tests as they've progressed, how they've become able to diagnose earlier and earlier HIV infection, as I was mentioning on that plot. Our current tests are called fourth-generation antigen-antibody combination tests, and they measure both the P24 antigen and IgM antibody and IgG antibody. And these turn positive on average within about 7 days of the time when HIV RNA appears in the bloodstream, or about 17 days after the person has acquired HIV. The older generation tests take longer to turn positive, and so miss the very early events of HIV infection. These are the tests that are run in most clinical laboratories in Michigan: the fourth-generation initial test, and then the supplemental test, the discrimination assay. So this fourth-generation test, often run on the Abbott Architect machine, although there are other machines that can do this in a laboratory as well. A laboratory-based test measuring the HIV-1 P24 antigen and measuring both IgM and IgG for both HIV-1 and HIV-2. So turning positive, again, within about a week of when the virus appears in the blood. These machines are very fast, they're very automated, they're extremely reliable because they're so automated. They can run a sample in half an hour. These machines can run large batches of hundreds of specimens in a short period of time, and they can be set up to run stacked specimens. So they can do a rapid test, as it were, even though it's a laboratory-based test. There is a stacked way of running a fourth-generation laboratory test. There is also a point-of-service fourth-generation test. The Michigan Department of Health and Human Services funds many test sites around the state, STD clinics, health departments, and so forth. And we all use the Alere Determine point-of-service fourth-generation test in those sites. This also tests for HIV P24 antigen and the IgM, IgG, HIV-1/2 antibodies. So it's testing for the same thing as the Abbott Architect. It's not quite as good. It takes a couple of days extra for the allele determined to pick up the P24 antigen, and it's a little tricky to read. And we have seen a little bit of false positives on this test, but it is very convenient. It just takes a big drop of blood, and it runs in about 20 minutes, and we rely on this in the STD clinic, for walk-ins at our HIV clinic and around the state. This is a very important test. If either of these are positive, you need a second level test. This is no longer the Western blot of years ago. It's now a discrimination assay. For many years, it's been the multi-spot test. The company has switched from making multi-spot to Genius, but it's the same idea. These are antibody tests that look separately for HIV-1 antibody and HIV-2 antibody. So this is the sequence, and a lab will automatically go from a fourth generation test to this discrimination assay if you sent the sample to the lab. If you have a positive point of service test, you have to send it on to the lab for the second level of testing. There is a third level of testing, which is looking directly for the nucleic acid. This takes longer and is more expensive, so it's not normally used as the initial or screening test. Just the ordinary HIV viral load that's used in clinical care could be used for this. It has a lower limit of detecting 20 RNA copies per ml, and most people with acute HIV infection have hundreds of thousands or millions of copies. So usually it will work, although it's not really licensed for diagnosis. There is a licensed RNA test meant for diagnosis. It's qualitative rather than quantitative, so it doesn't provide a number or viral load. It just tells you HIV infection is present or not present. HIV RNA is present or not present. It's more sensitive than the viral load test. And again, it's licensed for diagnosis. So this would be a third step in testing, as I'll show you. There are HIV DNA tests that are licensed for testing in newborns, but we're not talking about newborn diagnosis today. So here's the scheme for using these tests. At the top, it starts with that fourth generation HIV 1 and 2 antigen antibody combination test. And if it's negative, it's negative. If you think the person might have caught HIV within the last 2 or 3 weeks, they should be retested perhaps in another month. The window period is much shorter with these tests than with the first generation tests where we retest people 6 months later. Here, a month later would be a good time point to repeat a test if there was a recent exposure. If that fourth generation test is positive, then we go on, as I mentioned, to the discrimination assay, which will look for either HIV-1 antibodies and report those, as you see in the graph, or HIV-2 antibodies, much less common in the U.S., but occasionally are here. We have one HIV-2 patient at our clinic. Sometimes both antibodies will be detected, and the person may have both infection, or the kit may be having trouble distinguishing between the two. And that antibody test may be negative. Why would it be negative? Well, perhaps the fourth generation test is wrong, or perhaps the person has HIV antigen, but this discrimination assay doesn't test for antigen, only antibodies. So the fourth generation test can be positive a week before the discrimination test is positive. In that case, we'd expect there to be plenty of HIV RNA in the bloodstream, and the lab should automatically send that specimen on for the diagnostic HIV RNA testing, the qualitative RNA test, which will either confirm HIV infection or prove that there is no HIV infection at that moment. So if you order the fourth generation test at your lab, this whole sequence should run automatically without you requesting the individual steps. If you get something like this and you're not sure how to interpret it, by all means get in touch with your consultant or the people that we mentioned at the end of the slide to provide backup and HIV care for you. So HIV testing in the United States, what's the strategy? CDC recommends opt-out testing, which is that the patient is told an HIV test will be done and has the option to refuse, but otherwise things just proceed. And I will tell you that Michigan law does not specifically support opt-out testing. The rules are a little bit more stringent, as I'll describe to you. CDC recommends that there's one-time HIV screening of all persons between 13 and 64 years of age. If someone is younger than 13 and has potential exposures, if someone is over 64, did you know that people over 64 might have sex? If someone is over 64 and has potential exposures, testing is appropriate for them as well. And other than the one-time screening, people who have higher risk or ongoing exposures should certainly have more frequent testing. People who have sexually transmitted infections, people who have multiple partners or repeated partner change, people who are trading sex for money or drugs or other favors, people who are using drugs, people who have an HIV-infected partner. There's many reasons that a person could be at higher risk and for which one lifetime test is not enough, but perhaps a test once a year or even a test following specific exposures would be appropriate. So in Michigan, as I said, the rules are a little bit more stringent, and there is meant to be written or verbal consent for HIV testing in the medical record when you're doing HIV testing in a healthcare setting. This is a little bit different than a state-funded test site, which requires written informed consent and follows more stringent rules about counseling. But for this purpose, we're talking about your work in a healthcare setting. So there could be an item in your general consent to treatment that includes that the person might have HIV testing, and that is fine, and that gives you some written consent when the person signs it. But really, it should be clear to the person that they could refuse HIV testing and be consenting to other general treatment when they do that. In Michigan, prior to an HIV test, the patient is meant to be given an explanation of the test, the testing for HIV infection, not for AIDS or a disease, but for the presence of the germ, an explanation of how HIV is transmitted through sex or needle sharing, and how it can be prevented through safer sex, through not sharing needles. You're meant to explain the rights of the patient regarding HIV and testing, which include that the person can decline the test. Even after you get the blood sample, they can decline it up until the time that the result is available. They have a right to confidentiality, and they have a right to having an anonymous test, one without their name being used. If you're not able to do this in your setting, health departments and local health HIV service agencies can help the patient access an anonymous HIV test. The person is also supposed to get information about who might find the results of their test, even though they're considered confidential. And like other health information, a health insurance company, including Medicaid and Medicare, can get that information. In Michigan, there is name reporting of all people who test positive to the state health department. The health department holds that information confidential, but counts each person who has HIV and takes certain preventive steps, as I'll describe. And of course, other healthcare providers involved in a patient's care who have access to the medical record will see those results. And Michigan emphasized that a clinician must inform patients of both positive and negative tests. So it's not good enough to not tell them if it's negative. You got to give your patient a negative result as well as a positive result. So to try to make this more streamlined, the state health department created a pamphlet which you can give to your patient that satisfies all the legal requirements about informing your patient. These pamphlets are available in English and Arabic and in Spanish. They can be downloaded from this URL that's on this slide, and you can email ctrsupplies@michigan.gov to order hard copies. This is an image of that document, What You Need to Know About HIV Testing, which lists in slightly more detail the items that I just described. And providing the patient with this, and they're agreeing to have an HIV test, fulfills the law, and you then write in your notes that the person has received the information and agrees to HIV testing. And that satisfies the Michigan legal requirements. A little bit more about HIV testing in Michigan. Michigan has an aggressive stance about testing in pregnancy because we would like to see no perinatal transmissions. And the way to achieve that is to make sure all HIV in pregnancy is diagnosed and women have the chance to have an intervention. So 2 tests during pregnancy for all women in the state at the time of diagnosis of the pregnancy and at 26 and 28 weeks of gestation. A 3rd test is in the Michigan guideline for high-risk women at 36 weeks or at the onset of labor. So women having partner change during pregnancy, women who have an HIV-infected partner, who have a new partner, who have had STDs. If a woman is injecting drugs, we hope they're not during pregnancy, but any kind of exposure, a 3rd test is very appropriate, and that would usually be a rapid test done at the onset of labor. In Michigan, there's a special law about confidentiality besides HIPAA, which means when a person is signing a release of information, in Michigan, they're supposed to specifically okay release of HIV information, mental health information, or substance use information. And so most releases of information in Michigan, proper forms, will have a place where a patient can indicate that they do or do not agree for that information to be included in the release. There is a duty to warn, so that physicians must warn someone who is known to be at risk from the patient that you are caring for. You can take care of this responsibility by asking and involving the local health department. So if you have a patient and you know their sex partner, your patient is infected, you're responsible for doing something to make sure that current partner is advised of their risk. You can do it yourself, you can do it with your patient and the exposed partner, or you can refer this to the local health department, which is more often what happens. More generally, the local health department can provide partner services, and they're interested in speaking with anyone who is exposed to your HIV patient even over the prior year, not just someone who might be exposed tonight or next week. And for this, disease intervention specialists would interview your patient, find out who the possible contacts are. They will interact with those possible contacts without revealing the name of your patient. But say you might have been exposed to HIV, they would try to get the person in for a test, and if they're positive, of course, follow up to try to get them into care. And they do this without naming the index patient, your patient who might have been the source of infection. Of course, your patient might have caught their infection from this person DIS contact, so the direction is not certain. But this is a very important step in trying to interrupt transmission. So we'll turn from HIV testing to HIV prevention in 2016. And there's really 3 different ways antiretrovirals are used for prevention: treatment as prevention, or TASP, or antiretrovirals given to a person who has HIV. So they're getting it for their own health, but it also lowers their viral load and reduces their chance of transmitting HIV to another person. So as I showed you in that early CDC slide, this is a very powerful route to reduce future transmission by getting everybody who's infected engaged in care, treated, get their virus suppressed, which is the topic of the other slide set. PrEP is pre-exposure prophylaxis. It's for people who do not have HIV infection. They take medicine before and continue it after possible exposures to HIV. We'll talk more about that. And PEP, post-exposure prophylaxis for someone who's not HIV, is when medications are used only after an exposure. So the example of a healthcare worker with a needle stick from an HIV-infected person, or a client who's had a sexual assault and may have had HIV exposure from that assault. We'll talk more about this as well. So first, pre-exposure prophylaxis. It's now known by the acronym PrEP. And there's a campaign in Michigan to expand this. There's a campaign across the United States to expand this. Excuse me. Truvada, the combination pill of tenofovir disoproxil fumarate, or TDF, and emtricitabine, or FTC, is a widely used medication as part of HIV treatment. And this 2-drug combination pill was licensed by the FDA in 2012 for daily use in HIV uninfected people at risk of acquiring HIV to help prevent the acquisition of HIV. And as I'll show you, this was proven in several randomized controlled trials to reduce infection, both among men having sex with men, among heterosexual men and women, and among drug injectors. And as I'll show you also, adherence is key. There's more than 90% protection among people who are adherent and have detectable drug levels. Effectiveness is much less when adherence is less. So this slide shows some of the randomized controlled trials that proved that PrEP works in these different kinds of patients. IPREX was a study of men having sex with men. Overall, 44% protection among the men who are randomized to take active Truvada every day compared with the men that were on placebo. In the partners PrEP, heterosexual men and women took either tenofovir Viriad as a single drug or the Truvada combination drug, and there was 67 to 75% protection for those who took active drug compared with those on placebo. This is all shown in the efficacy overall of the first column. Among Thai injection drug users, about a 50% protection rate for those that were using active drug, even while injecting, compared with those that were using placebo. However, adherence was not perfect in these studies, and as you see in the middle column, only a certain percentage of patients randomized to take the active drug had detectable tenofovir in the bloodstream. In IPREX, it was 51%, partners PrEP 81%, Thai IDU 67%. So between 50 and 80%, but not everyone had detectable drug. If you analyzed only the people who had detectable drug for the rate of protection, you see the protection is really much better. 92% in IPREX, 90% to 86% in partners PrEP, 74% in the Thai injection drug user study. So the benefits really depended on taking the drug. Well, we all know that you have to take the medicine for it to work, but the level of adherence was modest in these clients, and so adherence is critically important. Let me mention that since these randomized controlled trials were done, and there have been open-label studies of PrEP, where the person knew they were taking active drug and they knew they were taking something that was proven to work, adherence was actually much better. And the effectiveness overall in those studies was more in the 80 to 90% range. So things have improved since these randomized controlled studies. The very bottom row in this shows a study that didn't work. The Voice, that was done with heterosexual women. No efficacy was demonstrated, and it turned out that hardly any women in the study were taking the active drug that was prescribed for them. There was just a big misunderstanding with enrollments in that study. Women didn't really understand what the point of the tablets were, didn't take them very much, didn't think they were at risk. So this is kind of the worst case, giving the drug to someone who doesn't know why they should be taking it and doesn't think they're at risk. But in the right setting, extremely effective. Who should get PrEP? This is the CDC PrEP guideline with the lists of the people for whom it's recommended in the United States. The first column shows men with having sex with men. The second column, heterosexual women and men. And the third column is injection drug users. So among MSM, the priority are those who have an HIV-positive sexual partner, those who have recent bacterial sexually transmitted infections like chlamydia, gonorrhea, syphilis, MSM who have a high number of sex partners, MSM with inconsistent or no condom use, or those that are trading sex for money, drugs, or some other benefit. For heterosexual women and men, it's similar. If they have an HIV-positive sexual partner, recurrent sexually transmitted infections, high numbers of sex partners, inconsistent or no condom use, and commercial sex work. They also added heterosexual women and men in a high prevalence area or a high prevalence social network. And finally, for drug injectors, someone with an HIV-positive injecting partner, someone who's sharing injection equipment and not using needle exchange, or just maintaining their own injection equipment, And curiously, somebody who's recently been in drug treatment but is injecting again are considered to be at especially high risk. I think the notion is they're a little bit more careless if they've failed drug treatment and gone back to injecting. So all of these are categories of people for whom PrEP would be a big benefit. How do you implement it? This is something you can do in your practice. This is a licensed drug and you have access to all the tests. Baseline testing would be a fourth-generation antigen-antibody combo test, what we had earlier described. There's hepatitis B testing, because Truvada is also a hepatitis B drug, and you need to know if you are treating someone for hepatitis B at the same time you're providing PrEP. You need to do a serum creatinine, because the main potential toxicity of Truvada is on renal function. And you should do sexually transmitted disease screening, because you're doing this for people who are at risk of STIs. We should find them, diagnose them, and treat them. There needs to be a mechanism to pay for Truvada prescriptions. In Michigan, Medicaid pays for it. Healthy Michigan, expanded Medicaid pays for it. At the current time, so far as I know, all the pharmacy plans will cover this. Someone who's uninsured will need help accessing it, but there are mechanisms to help even people who are uninsured. MyDAP, which provides medication for treatment of HIV-infected people who are uninsured, cannot pay for PrEP medications, but there are other mechanisms. Once someone has started on treatment, they have a follow-up visit after the first month, and then every 3 months. You should give them a prescription only to last until their next visit, because we don't want them continuing on PrEP without periodic checks for HIV infection that they might have acquired. If a person catches HIV and stays on Truvada, which is only 2 antiretroviral drugs, they can develop drug resistance, which we mean to avoid. If something goes wrong and a person prescribed PrEP catches HIV, we want to make sure we get them on a full treatment regimen, not the partial regimen of Truvada. Therefore, this testing periodically is quite important, and giving only enough refills to last till your next fourth-generation HIV test is critically important. Also, we should test for kidney toxicity by doing creatinine 3 months after they start medication and every 6 months thereafter. The rate of toxicity is low, especially in young, healthy people, but in older people who have some kidney abnormality to start with, there's a higher rate of having creatinine effects with this medication. If someone has hepatitis B infection, if the hepatitis B surface antigen infected, you have to roll into this monitoring and treatment for hepatitis B. I'm not going to go into that in detail now, but as long as you do the test, you know which way to go. If they've already been vaccinated and immune and you've documented that, that's great, then there's no worries. If they haven't been vaccinated, you could vaccinate them and give them an extra tier of protection as part of your primary care. It's important to avoid interruptions of Truvada, a hepatitis B medication, in someone who has hepatitis B, because sometimes there is a very severe flare of hepatitis B with hepatic necrosis when someone interrupts hepatitis B treatment. So that's another reason you have to know if you're treating Hep B as you start PrEP, and just build that into your treatment plan and your adherence plan. Since adherence is so critically important and we're asking a perfectly healthy person to take a medicine every day, adherence assessment and support is critical for this to work. And you have to continue to assess their risk behaviors as you see people every 3 months, because maybe somebody's lifestyle has changed and they no longer require continuing Truvada, or maybe for a period of time they won't need it and they come back to you when their lifestyle changes again. At every visit, we recommend screening and testing for chlamydia, gonorrhea, and syphilis. Depending on the sex somebody is having, chlamydia, gonorrhea testing might include oral swabs, might include anal swabs, along with either a urine or a urethral or cervical specimen, because we're looking for these STDs at every site. We should expect people that we're giving PrEP to get sexually transmitted infections. We're giving them PrEP because they're at high risk for these things. Some physicians and mid-level practitioners in Michigan are uncomfortable with PrEP because they feel that it's enabling risky behavior. This is a very important public health intervention. For 10 years, we tried to reduce HIV transmission with counseling and condoms, and it didn't work. It didn't reduce HIV transmission in the U.S. for 10 years. So we were very excited to have another route to help people avoid getting HIV. And yes, it's very nice if people change their lifestyle and avoid HIV infection moving forward. However, for many people, that's not going to happen. And doing the harm reduction intervention of offering this is a very, very important public health intervention, which can help reduce the epidemic in our state and the epidemic across the U.S. This is being promoted around the world. So we really ask you to take part in this. Suspend judgment, work with your patients, and do everything you can to help them have good health moving forward. You should periodically reassess whether PrEP is appropriate. People's lifestyle change, as I said, and sometimes somebody needs it and then doesn't need it. We don't expect PrEP to be a lifelong intervention. And we have developed, to help you, a toolkit for PrEP specific for Michigan clinicians, which you'll be able to access. The website will give you information about how to get that kind of help as well. There's lots of published guidelines and so forth with links on the website for general information, plus the Michigan-specific toolkit. I do acknowledge that condoms still have a role. They prevent HIV and pregnancy and syphilis and gonorrhea and chlamydia and trichomonas and herpes and HPV. So I'm not saying condoms are unnecessary, and I'm not saying a person must use condoms to get PrEP. PrEP is really for the people that are not perfect with using condoms, as you saw with the list of suitable clients. But condom promotion is useful, and it's good for all of these purposes. So it's good to have combined interventions for prevention. Promoting condoms as much as they can be used, PrEP for suitable patients, and moving forward. So I want to touch briefly on post-exposure prophylaxis. This is the use of medications after an exposure. It was first developed for occupational exposures for healthcare workers that had usually a needle stick, perhaps a mucosal splash of blood from an HIV-infected patient. And then it was expanded with a CDC guideline for non-occupational exposures as non-occupational post-exposure prophylaxis, used often for persons who had a sexual assault, but can also be used for other lifestyle exposures. It doesn't have to be a sexual assault. So PEP is using 3 drugs for 1 month of treatment. The original study that proved that PEP worked was many years ago, and it was a much smaller kind of intervention. It was 1 drug. At the time, only retroviral zidovudine was licensed. Healthcare workers took a month of zidovudine. In an observational data from the U.S. and Europe, there was an 80% reduction in acquiring HIV for healthcare workers that took that month of retroviral zidovudine after a needle stick from an HIV-infected donor compared to those who did not take any medication after a needle stick. These are the only human data. However, there are a lot of animal data to support this, but these are the only human data. Nowadays, we do much more intensive medication treatment for PEP, as we do much more intensive use of antiretrovirals for treatment. Currently, PEP is a 3-drug combination of that same Truvada combination pill of 2 drugs that we've been discussing already for PrEP. And added to that is an integrase strand transfer inhibitor, either the Icentris medication, also known as raltegravir, a 400 milligram tablet twice a day, or Tivicay, also known as dolutegravir, a 50 milligram tablet once a day. So Truvada plus Icentris or Tivicay for a month. It is important to start this as soon as possible after the exposure, preferably within hours of the exposure. And the animal data show that it's probably ineffective if you wait more than 72 hours to start these medications after the occupational or non-occupational exposure. So getting this going rapidly is extremely important. And as I mentioned, the whole course is for 4 weeks. So it takes HIV testing the donor, if you can, to know if there's really been an exposure. We can do that in healthcare settings, but not usually in sexual assault settings. HIV testing the recipient to make sure they weren't already HIV infected, in which case we should be enrolling them in treatment rather than offering PEP. Doing some chemistry tests to make sure there's no chemical risks, abnormal renal function, and so on, so we can monitor for toxicity. And here again, really healthcare workers haven't been great at taking the pills, so adherence counseling for post-exposure prophylaxis is very important. In order to get started fast, sites that might be doing this should have a 5-day supply for their patients available that they can dispense. Emergency departments and other acute settings should have a 5-day supply to hand the person, besides for arranging a prescription so that the person can get started right away. And this 5-day supply is specifically endorsed in the Michigan Department of Health and Human Services and PEP guidelines that are on the website at the URL that's at the bottom of this slide. Even for someone with insurance, if it's Friday evening, they may not be able to get to a drugstore that has these medicines on their shelf till Monday or Tuesday if it's a 3-day weekend, and immediate treatment is what's protective. We wouldn't tell our colleague who had a needle stick to wait till next week to start this treatment, and so we shouldn't tell someone with a non-occupational exposure to wait till next week. If they have insurance, they can fill a prescription. If they don't have insurance, we have methods of getting them a continuing supply, adequate for that 1-month treatment, so they have to get to an HIV provider, health department, STD clinic that can help them access the ongoing treatment before the 5-day supply is used up. Moving on then to primary care of HIV-infected persons. Here I am talking about primary care to primary care providers. I'm going to be describing things you already know, but I'm going to be putting them in the context of how it might differ for someone with HIV infection than from your general population. And most of these recommendations come from the Infectious Disease Society of America guidelines on primary care for persons infected with HIV. For youth, for young children, for young teens, these will be a little bit different. This is really for older adolescents and adults. So there's minimum baseline data a patient with HIV will get to establish antiretroviral therapy. And this is gone over in more detail in our companion video about antiretroviral therapy, but includes an HIV viral load, a CD4 count, HIV genotypes for resistance testing, a hepatitis B surface antigen, CBC, creatinine, liver function tests. Depending on the medicines you'll give them, you might need to know an HLA-B5701 result to know if a Visagen or abacavir-based regimens are safe. You'd like to know their pregnancy status because that impacts on a choice of antiretroviral regimens. So you might do this whole set of testing in someone who has newly diagnosed HIV in your practice, so that when you send them to a consultant to start treatment, they already have all these results, or you might defer to the consultant to do these. If you're going to do the antiretroviral therapy yourself, of course, you need this baseline information. Other than that, I'm going to move more to the primary care part of HIV care. So there's a whole series of things: hepatitis, STDs, toxoplasma, lipids, diabetes assessments, urine testing for kidney function. We'll go over these in a little bit more detail because these are the things that would be done in primary care, not necessarily followed by the HIV treater. So we need to know someone with HIV if they have infection or immunity to the other hepatitis viruses. So hepatitis A antibody screening at baseline is important. Hepatitis B testing for surface antibody for immunity, for surface antigen, which would mean probable active infection, and for core antibody, which is sometimes something in between. All those tests are done at baseline. And for hepatitis C, antibody testing at baseline is also important. There is a fairly high rate of people with HIV acquiring hepatitis C after a negative baseline test. It's true especially among drug injectors and active men having sex with men. So we recommend actually ongoing annual hepatitis C testing for those who have a negative hepatitis C antibody test. For those who have a positive hep C antibody test, 20% of them will have already cleared the virus and 80% will be actively infected. So you go on to do the HCV viral load to confirm they have active infection and then proceed about hepatitis C treatment, which has definitely got to be a different video. We won't talk about that more today. For STD evaluation, syphilis testing is baseline and at least annually for persons that plausibly have ongoing exposure. We do syphilis testing pretty much on everyone with HIV in our clinic, whether they need it or not. I tell them that so they don't feel defensive about the testing. Young men who have sex with men have a much higher rate of syphilis in our state, and so that's extremely important group to be testing for syphilis on repeated occasions. Gonorrhea and chlamydia testing, we screen men and women at baseline, and then if they have potential ongoing exposures, at least once a year. If someone had gonorrhea treatment, we should repeat the testing within a month because there's increasing rates of resistance to the gonorrhea treatment drugs. If someone's had gonorrhea or chlamydia, we recommend retesting within 3 months because someone that's had it once is likely to catch it again. I will mention in passing expedited partner therapy to try to protect the partners of your patients with gonorrhea and chlamydia. If your patient has HIV and there's someone else they've exposed to gonorrhea and chlamydia, really they need a disease intervention specialist and partner services because they need HIV testing too, not just chlamydia tablets. So following up on those other exposures becomes even more important when your client has HIV. And as I mentioned earlier, you have to sample every exposed orifice. So often for our patients, there's an anal swab, an oral swab, and a urine specimen or urethral and cervical swab, urethral or cervical swab to look for gonorrhea, chlamydia. The chlamydia is not certain to exist in the throat as a disease, although we treat it if we find it. So some people only test for gonorrhea in the throat. And some of the licensed tests, which are really only licensed for urethral and cervical testing, don't perform well on throat testing. So you can call with questions if you're not quite sure how to interpret some of these results. When in doubt, we treat. And we're hoping that the technology advances and there'll be FDA-approved swabs for oral and anal testing for gonorrhea and chlamydia in the near future. Women should have trichomonas screening for another STD. There's underlying this the chlamydia screening for all women under 25, regardless of HIV infection. Pap test screening, including this as kind of an STD because of HPV infection. Pap test screening is a little bit different for women with HIV than the general population. As in the general population, for women 21 to 29 years old, they should get an annual Pap and only have HPV testing on that annual test if they have ASCUS, but they should not have routine co-testing for HPV in the age range 21 to 29. For HIV-infected women, if they have normal annual PAPs for 3 years in a row, then they can have a Pap smear only every 3 years. For HIV-infected women, once they turn 30, they have a Pap smear with concurrent high-risk HPV co-testing. That means on your sample that you send for a Pap smear, you also send it to test for the HPV types that are associated with dysplasia and cervical cancer. This is a recommended intervention for women without HIV, as you know, and has now been included for women with HIV. However, outside of the HIV world, you can repeat this every 5 years in women who test negative. In the HIV world, where the risks of acquiring HPV and of disease are higher, you only can do this every 3 years for women who test negative. And in women with HIV who have high-risk HPV or abnormal PAPs, they pretty quickly go on to colposcopy to get more diagnostic information rather than just wait for another Pap smear being done sometime later. There's an interest in doing anal pap smears to try to screen for anal dysplasia and preventing anal cancer. And actually in the U.S., there is more invasive anal cancer than there is invasive cervical cancer. But this is a partial recommendation because how to follow up an abnormal anal pap is sometimes difficult in some settings, and so I won't go into that further in this discussion. TB testing at baseline and pretty much every year is recommended. You can do the standard tuberculin skin tests. Many people now prefer to do the blood tests, the interferon gamma releasing assays. 2 are licensed, the quantiferon gold test, or the T-spot TB test, whichever your lab has access to is great. Some people like to repeat the TB testing if it was negative initially in a person with a low CD4 count, because their immune system will be more responsive and it may show TB infection that you missed if you repeat the TB test after the CD4 count rose to above 200. For people who test negative, we usually do an annual TB test with either a TST, Quant Gold, or T-spot. For people who are positive on one of these tests, you'll go ahead and try to rule out active TB with a chest x-ray. If there's sputum, you might do sputum samples for AFB smears and culture. If you prove someone has no active TB, everyone with HIV who has latent TB requires treatment for latent TB. And there's a few regimens that are possible. You can look them up or call us to help guide what regimen would be suitable for your patient depending on the other medications they're taking and drug interactions. Other opportunistic screening and prophylaxis involves PCP prevention, pneumocystis pneumonia. As you know, for persons whose CD4 count is under 200, they should take a Bactrim double-strength tablet once daily or 3 times a week, which is extremely effective in preventing pneumocystis. For sulfa allergy or intolerance or renal conditions, Dapsone 100 milligrams once daily is very good. There is a low level of hemolysis even in people G6P negative, so I don't give Dapsone to people with anemia. A third choice of Mepron or Atovaquone, a very bright yellow, bad-tasting liquid, but 10 mils once a day is extremely effective in preventing pneumocystis and avoids the issues of Bactrim allergy or Dapsone in an anemic patient. Toxoplasma prophylaxis should be given for anyone whose Toxoplasma IgG test is positive and their CD4 count is 100. If they're on Bactrim, they're already covered. If they're not on Bactrim, there's a few different things you can do that they might tolerate, and it's good to call for more advice. I can't list all of those regimens in this short presentation. Amavian prophylaxis is recommended for everybody with HIV whose CD4 count is under 50. The regimen is Zithromax or azithromycin. There's a 600 milligram tablet made for this purpose. A patient takes 2 of these once a week or 1,200 milligrams once a week until the CD4 count rises to over 100 on successful antiretroviral therapy. And finally, for persons whose CD4 count is quite low, under 50, we've always recommended a dilated retinal exam to look for very peripheral early CMV retinitis. No prophylaxis is used for CMV in persons with HIV, but monitoring for CMV with an eye exam is very appropriate and non-invasive. Vaccinations, or you do vaccinations all the time in your patients for primary care, but some of the indications are a little different. Everyone should get an annual flu vaccine, but in HIV-infected patients, we prefer the inactivated to the live virus vaccine. Everyone with HIV needs pneumococcal vaccine, and sometimes this is hard to get it paid for, but it's quite important. They should get the Prevnar 13 or the conjugate vaccine once, followed 2 months later by the polysaccharide 23-valent vaccine, Pneumovax. If they get the Pneumovax first, you have to wait a year before you give the conjugate Prevnar vaccine. Once they've gotten the Prevnar 23 vaccine, they're supposed to get it 1 more time, either when the CD4 count goes up over 200, or 5 years after the initial dose, or at age 65. But at this time, 2 Pneumovax and 1 Prevnar is the whole package for an adult with HIV. It doesn't have to be repeated every 5 years. People with HIV, like everyone else, should get tetanus, diphtheria, adult pertussis vaccine. And of course, there's special rules about using Tdap in every pregnancy to protect infants from possible exposure to pertussis. Once someone has had Tdap, they get tetanus, diphtheria, adult diphtheria every 10 years. So that tetanus vaccination is the same as the general population. We recommend, of course, Hep B vaccination to everyone with HIV who's not already immune or not already infected, with the standard 3-dose regimen at 0, 1, and 6 months. The catch is the response rate is rather low. We recommend getting a repeat hepatitis B surface antibody a month after you finish the vaccine series. And if the person has not responded, we recommend you try again. No one is sure of the best way to try again. Some people wait till the CD4 count is over 200, if it was lower before, and then try a standard regimen again. Others, based on a randomized controlled trial, wait till the CD4 count is over 400 and then give a double dose revaccination. 2 doses at time 0, 2 doses at month 1, 2 doses at month 6. This certainly increases the response rate. It's expensive and not always covered by insurance. People who have just hepatitis B core antibody might be infected. You could check that by doing a Hep B DNA test. If they don't have Hep B DNA, you could try vaccinating them because they may not be immune. And if someone has Hep B, you should make sure everyone in their household is vaccinated. Non-immune sex partners and non-immune household contacts of someone with Hep B should be vaccinated. Hep A we recommend, especially for men who have sex with men, drug injectors, anyone who has Hep C or Hep B. Really, we do this for all of our HIV patients. It's the standard 2 doses at time 0 and the second dose at 6 to 12 months. Again, we recheck a Hep A antibody a month after the vaccination to see if it worked. And if it didn't, we'll try one more time with one more series. People of the right age with HIV should be vaccinated for human papillomavirus, ideally with the 4 or 9 valent newer vaccines that can protect them against some of the wart-causing viruses, along with the dysplasia-causing viruses. As you know, this is 3 doses given at 0, 2, and 6 months. It's legit and paid for men and women, ages 9 to 26. Ideally before sexual activity. If you're taking care of someone with HIV, they've probably already started having sex, but it is still worth in someone under 26, if you can get the vaccine paid for. This is immunogenic, proven immunogenic in persons with HIV, proven to reduce the onset of warts in persons with HIV, and we hope would reduce both cervical and anal dysplasia and cancer in persons with HIV. 2 live viruses, the indications are a little less clear. For someone, a child who would be getting varicella virus, this is a live attenuated virus, and I think the pediatricians will usually give this if the CD4 count is high enough that they feel it's safe. Zoster, which is basically high-dose varicella vaccine for older adults to prevent a relapse of the chickenpox virus causing varicella, has never really been studied in people with HIV. In principle, you could give it to someone over 60 whose CD4 count is over 200. There's not really uniformity of what to do with this, and even the guidelines hedge. If the CD4 count is very high, you may feel more comfortable. Of course, you're going to monitor blood pressure. You're going to look for signs of diabetes. People on ART, especially protease inhibitors that can cause insulin resistance, probably have a higher rate of developing diabetes, usually associated with family histories or increased weight or other risks. You have to watch lipids because many of the HIV drugs increase cholesterol and triglycerides, and that might have to be treated. So on antiretroviral therapy, every year we check lipids at least. Bone densitometry, bone density decreases faster in people with HIV than in others, and sometimes is associated with the medication. So it's a softer recommendation, but still a recommendation to do bone densitometry on postmenopausal women and men over 50. I can't say we're very consistent at this, but really we should be doing this to try to avoid fractures in our patients. and the ultrasound exam for abdominal aneurysm is the same as in a non-infected person. Cancer screening, well, I think it's important because of the high rate of non-HIV associated cancers to be very thorough in cancer screening in your HIV infected patients, to follow the guidelines. So an annual mammogram at least at age 50, individual assessment for women 40 to 50 years old. I tend to do it in HIV infected women, even though the benefit and risk is differently assessed by different groups. U.S. Public Health Service recommends against younger women. American Cancer Society recommends for. I will do it in an HIV-infected women. Clinical breast exam, also recommended by American Cancer Society. The cervical cytology we already discussed. Colonoscopy, very important. These are things you're used to doing, but we should be very careful to keep up with them in persons with HIV, since they seem to get cancers more easily. Not on this list is the idea of low-dose CT to screen someone with a lot of high smoking history. I've seen lots of lung cancer in my smoking HIV patients, and so I think this is another item. It wasn't in the IDSA guideline because that idea came up since 2013, but it may be something to consider, especially if it can get paid for. Focusing on women's reproductive health, we talked about syphilis testing, trichomonas testing, gonorrhea and chlamydia testing. It's important to talk to women about childbearing plans. Some of the HIV medicines are better or worse during pregnancy. And all of the oral contraceptives have problems with almost all of the antiretroviral drugs. I've seen almost always that women are prescribed hormonal contraceptives that don't work with the antiretroviral that they're receiving. So really you've got to look this up and coordinate with the person prescribing their antiretroviral drugs. Icentrus and Tivicay are all right, but most of the other regimens don't match with hormonal contraceptives. They need injectable or subcutaneous or an IUD or something else if you're going to use a contraceptive method on top of condoms. Hormone replacement therapy is recommended against in HIV-infected women because, in part, they're thought to have a higher risk for atherosclerotic disease with that immune activation. So usually no hormones for contraception are problematic, but can be used if you're very careful and you're choosing carefully. Hormone replacement therapy is not recommended. For women, there's been some people giving testosterone, but there's no proven benefit in HIV-infected women, and we discussed the cancer screen already. For men's reproductive health, again, the STD testing, some men with advanced disease do have low testosterone, and replacement is reasonable if they have measured, proven low testosterone levels. With all the advertising on TV, many men are asking for this, but I encourage you to actually test and find out if the person really has low levels before you're prescribing. It's been common in people with low CD4 counts in HIV, not so common in people with controlled virus and high CD4 counts. Let me mention one other thing about preconception planning. Many couples with HIV want to have a child, and if one person in a couple is infected and one person isn't, then you have this issue about how do you prevent transmission within the couple while they're trying to get pregnant. Condoms don't work very well for couples that are trying to get pregnant, so you need to come up with some other plan. Pre-exposure prophylaxis is now used sometimes for the non-infected partner while the infected partner has a controlled virus on treatment. But it's really something worth discussing in advance because a couple can plan around this, reduce the chance of HIV transmission within the couple, and find a way to have uninfected children and have the family that they desire. If your patients are asking you about this and you're not sure how to proceed, this is another good reason to get in touch with the HIV experts listed at the last slide in this presentation. Many people with HIV will be upset with the new diagnosis. Others will have pre-existing mental health disorders. They might have experienced or have ongoing issues of domestic and intimate partner violence. So Screening for this and linking your patients to services is very important as part of primary care for someone with HIV. And this whole list of things to try to make sure your patient is less likely to transmit HIV is quite important. Screening for sexual activity, screening and treating for sexually transmitted infections, talking about drug use, getting treatment for drug use, reinforcing with your patients the Michigan law that requires them to inform their partner of their HIV status. And the Michigan law still specifies that the HIV-infected person is supposed to be using condoms with every act of insert of sex, even if their virus is controlled. And I mentioned for a moment already preconception counseling. Just one point about antiretroviral therapy, because that's the topic of our companion slide set. When to start. Nowadays, everybody with HIV can benefit from antiretroviral therapy for their own health because the drugs are so safe, so effective, with a quite low risk of drug resistance. So everyone with HIV is eligible for antiretroviral therapy for their own health. In addition, providing them with antiretroviral therapy and controlling their virus will make them less infectious, protect their partners, and also help reduce transmission moving forward. And of course, patients getting antiretroviral therapy must be educated and supported to maintain lifelong excellent adherence with medications. Details on antiretroviral therapy are the subject of the companion video. So I want to close with the idea of integrated HIV care and prevention. There's biomedical aspects and psychosocial aspects. We've talked about many of these. HIV testing, for people who are HIV negative but high risk, we can offer them PrEP and primary care. For people who are HIV positive, rapid initiation of antiretroviral therapy, either in primary care or with a consultant, is very important. And a primary care provider has to be very careful to watch for drug interactions with the antiretroviral regimen, whoever is prescribing them. STD screening and care, hepatitis screening and care, managing cardiovascular risks, cancer screening, and then testing partners and providing PrEP for at-risk partners are all very important interventions for the primary care provider. In addition, parallel with that, and to make these things successful, there's access to insurance, there's access to medical care, adherence with care and medications, behavioral health issues we mentioned, housing and food security. It's very hard for someone to take medicines if they have no home, if they're in a shelter, if they don't have food in the house. There are HIV service agencies that can help with this. And a person has to have the self-efficacy and willingness to take care of themselves and overcome how they experience stigma and discrimination to make this successful. So for HIV-infected people, you often need HIV case management and other support structures to make this effective. So to provide extra information for you and help with decision support for individual patients, MDHHS has provided several options. There's a new Michigan HIV consultation program run by Henry Ford. They have a great website with lots of information, links to many detailed guidelines, and you can pose your questions on that website and have answers within 1 or 2 business days. There's also a phone line for urgent questions with 24-hour response. At Maytech Michigan, we also can provide responses to your questions by using the email address or the phone number we list for urgent questions. So we really appreciate your attention. With your participation, Michigan can drastically cut down HIV in the next 5 years and look forward to the end of the epidemic.